During pregnancy, the uterus increases in size, and whenever it obstructs the inferior vena cava, it is also obstructing its own venous return to the heart. This obstruction increases uterine venous pressure. Could this phenomenon be a cause of dysfunctional labor? Positional inferior vena cava obstruction is a well-known problem in pregnant patients. But now we can detect this obstruction in real time by trending maternal cardiac output using electrical cardiometry. The key insight is that obstruction of the inferior vena cava reduces venous return to the heart, and that venous return is the same as cardiac output. Here is the normal maternal circulation during labor, without obstruction of the vena cava by the pregnant uterus. The blood pressure is good, the uterine venous pressure is low, and the already high cardiac output increases even further during uterine contractions in a process called autotransfusion. Here is autotransfusion in a laboring patient with an epidural in place. She is lying comfortably in bed, tilted about 30 degrees to the left, and each painless uterine contraction is followed in about 30 seconds by an increase in the maternal cardiac output. This is what happens when the mother lies flat on her back and allows her uterus to obstruct its own venous return. Obstruction of the inferior vena cava decreases cardiac output and increases uterine venous pressure. Could uterine hypoxia cause dysfunctional labor as well as fetal distress? Here is what it looks like in a patient when we use a reduction in maternal cardiac output as a marker for inferior vena cava obstruction. In the first half of this 70-minute record, the patient is lying on her right side and cardiac output and blood pressure are low despite the administration of vasopressors. Once the patient is turned onto her left side, however, the inferior vena caval obstruction is relieved and both cardiac output and blood pressure recover without any need for vasopressors. So, our theory is that uncorrected inferior vena cava obstruction during labor might cause dysfunctional labor, uterine atony, or uterine infection. Earlier in gestation, chronic uterine venous obstruction might accelerate the onset of preeclampsia, cause stillbirth, intrauterine growth restriction, or preterm labor. These are all just theories, but they should be investigated.